Good evening, everyone. Tonight we're going to be on with Dr. George Kotsakis. Let me connect with him right quick. There he is. Hey, George, how are you?
Hey, Shane, good evening. How are you?
Great. Hey, appreciate you joining us. I'm going to just introduce you. I think you're someone that is very well known and somebody who I think I see sort of, I think you're lecturing more and more at big symposiums and big annual meetings. I think you're kind of an up and coming guy from a public perspective. But in case anyone doesn't know, George, Dr. Kotsakis is a periodontist from originally from Greece. Did talk about your education background. I kind of knew you when you were at Washington at the program
Right.
there doing research, where we started doing some research together. And then I know that you're at University of Texas Health Center there in San Antonio now. But maybe you could just start off with just a short background for anybody in the audience who doesn't know you.
Yeah, totally. Thanks for the introduction. Well, I did my DDS in Athens, Greece, and then I came over in Minnesota for residency in 2012, which I now realize it feels like yesterday, but it's been a decade. So that's crazy. And then I moved on. I started my career at the University of Washington, and I think that's when we met because very early on, it must have been over 5 years now or 7 years that we've been planning our periimplantitis clinical trial uh, that was finally completed. So I kind of started my career there, and eventually I moved down to San Antonio, UT Health
Yeah,
San Antonio, where I'm at right now. And I do a couple of things. I'm an associate professor in periodontics and an endowed professor in implant dentistry there. I run my translational periodontal research lab where we do both the translational in vitro, animal work on periimplantitis and also the clinical trials. And then I chair the ITI Scholarship Center there. So, for the past decade since my grad work, which was focused on periimplantitis, I've just been so fascinated by how little we knew about this
yeah,
problem, and I've been focusing on that. A lot of the early days, when we met at UW, was focused on just convincing people about the magnitude of the problem, about the severity of the problem. And once that was done, we were finally able to really focus on how do we tackle this? How do we manage periimplantitis?
awesome. So, in how much are you in clinic right now versus teaching? Like, what does that mix look like for you right now? Just curious.
Yeah, I spent about a day a week in clinic, either working with our residents, which is a lot of fun and very gratifying, and seeing my own patients. Where honestly, because of limited time, I only see patients that have implant complications, periimplantitis, or other types of implant complications. And I just focus both my practice and research on that, and the rest of it is just focused on research.
Okay.
We have so many things going on that it's just that allocation of time. But what I've always tried to do throughout my career is you need to maintain contact with clinic. You need to be in touch. You need to see
Yeah,
what the
sure.
day-to-day problems are. And we kind of take pride in the lab that we're able to find clinical problems, take them to the lab, find possible answers, and then take them back to the clinic and do the big clinical trials and come up with hopefully clinical practice recommendations.
Awesome. So we're just going to jump in a little bit into, you talked about periimplantitis. I know that's where you've done some research that I'm particularly interested in discussing this evening. I think it's an area where everyone would like to know more. I feel like there's still maybe more questions than answers in some areas, but in some
Right.
areas we're kind of starting to get some answers thanks to research a little bit like yours, or like yours and other people's rather. You talked about starting off, you were just trying to convince people of the magnitude of periimplantitis. So what
Right.
is the magnitude of periimplantitis?
So that's a great question. I feel like it's very well accepted now in the literature that the prevalence of periimplantitis ranges somewhere between 10 to 20%, depending on whether you look at it, on the implant level,
Okay.
because some people might have multiple implants that may or may not have issues, or the personal level or the region. And it has a lot to do with some subtleties like how is it restored? Is it cement retained or resin retained, or screw retained? But I think the range of 10 to 20% is universally accepted out of systematic reviews and meta-analysis. That translates into, I always see a lot of value in translating things into layperson language, right? Not things that you and I or the audience would understand, but what our patient would get. And what we kind of need to be telling patients is that based on these statistics, 1 out of 5 to 1 out of 10 persons who get dental implants might develop a complication, an inflammatory complication that's called periimplantitis, and it's up your jawbone, and you might need further treatment for that. The problem being that now that we know how to diagnose that, we know that it can come in very, very early. Yeah. It can hit you within a couple of years or 2 to 3 years in function, which is tremendous, right? Because think about all the work preceding implant placement, guided bone regeneration, costs associated with the extraction, the grafting, wait periods, and then getting your implant and crown finally, and then 2-3 years later, having to go through major regenerative surgery all over again. So I think it's both recognized and both something that we got to incorporate in the way we communicate things to patients when it comes to dental implants.
Makes sense. How do you, is there a thing such as bacteria versus non-bacterial periimplantitis? Is it always bacterial periimplantitis, or is there bone loss around the implants that's not related to the presence of bacteria?
Yeah, man, you're just capturing the beat of the problem here. I think it's just $1 million question, because for a very long time, when I started looking into that problem around 2012, there was a lot of literature saying it's all bacteria related. It's exactly what happens around teeth. And, that led into a lot of, management strategies that were direct transfer knowledge from what we do around teeth. And that led to kind of a huge brick wall that we couldn't get through. I remember one of the most influential papers in the literature of periimplantitis is the Cochrane Systematic Review by Esposito in 2012 that said up to 100% of periimplantitis cases treated surgically might relapse within a year, which is a pretty horrendous statistic, like as bad as it gets. So I think that kind of killed the whole it's all bacteria hypothesis, because we know so well how to treat teeth that have bacterial-related inflammation, and we haven't gotten to a consistently effective treatment protocol for implants. So there's definitely more than bacteria. Now, I think one of the milestones in the field was that in 2017 at the World Workshop, we finally got a classification, right? We were going all the way from the 80s to 2017 without even having a classification of the problems. So we now know that you can get bone loss just because of poor biomaterial selection or poor surgical management during that place of biomaterial. So if you have a ton of residual particles around an implant and they surface, they find some sort of way to get exposed to their own environment. We've seen a lot of cases where sinus tracts form and they track all the way to the residual particles that we then have to excavate and be able to manage, hard tissue defects around implants. So that would be a biomaterial related issue. Tom Wilson in Dallas did a ton of work on cement, the excess cement related periimplantitis, right? So that's a whole niche in itself, where if you have excess cement, we know that there's 3 to 4 times higher chances than an implant that doesn't have excess cement to get periimplantitis. And there's a lot of bacterial studies that show that this resin cement is just food for bacteria. So what caused it? The cement or the bacteria? Yeah. That's kind of a good question. But then ultimately, we get to the point where if it's all bacteria, right, and we can't treat it with antibiotics, we can't treat it by grinding off all the biofilm from the implants by, burrs or ultrasonics or titanium curettes or you name it, then there must be something in addition to that. So I think the major breakthrough happened during the past 5 to 6 years in the field, where people started saying, okay, the biomaterial plays a role, because there's a lot of things that can happen with the biomaterial in the presence of bacteria, like breakdown, like titanium particles or corrosion of the surface, that then make this implant to not be biocompatible anymore. So I think we now have a first classification that says, okay, you might have a bacterial-related periimplantitis, and then you might have a non-bacterial related condition that's called periimplant hard tissue defects. Okay. But opening this umbrella of periimplantitis and further stratifying that, that's the real way to get, I think, to consistent treatment. Because again, there's a difference in how I treat an implant that has excess cement around it, an implant where I have, somebody ground the implant surface down with a burr, or an implant where I just can't find anything and it's full of plaque and biofilm.
You mentioned biomaterial, which, as osteogenics, we're always interested in. You talk about, so I assume we're talking about biomaterial contributing to periimplantitis, not necessarily treating periimplantitis yet.
Right.
So if we're using biomaterial, like which biomaterial are we placing implants into? Is there a particular type that you've seen, there's research to support that like is maybe a little more risky in terms of causing or contributing, maybe a contributing cause to periimplantitis?
Yeah. I wouldn't say there's consistent research, but I would say that there are case reports and clinical experience that shows us that sometimes when we try to overdo it, we actually end up causing long-term problems. Kind of a short-term fix can be a long-term problem. Prime example of that we see quite commonly in the clinic is contour augmentation. So let's say we have an anterior region area, we do immediate implants or early implant placement, and we always want to make sure we have long-term tissue stability. So a lot of folks, including myself in the past, we would pack a ton of long-lasting, like non-readily resorbing biomaterial, like certain types of denser alloplastic biomaterials or xenografts or whatnot, right? And not place a membrane, cover that with a graft, and create a nice bulk of tissue at the time. But we know very well, especially when you don't place a membrane, and that's in direct contact with the soft tissue, that a lot of that stuff is going to stay there for years, and it's going to get soft tissue encapsulated. So what we see now is when you overdo it, when it's really close to that implant abutment junction, we see a little bit of sinus tracts that sometimes, you have the bacteria kind of dive into that sac, that soft tissue encapsulation of the material, and form, they get pus coming out of it, form little sinus tracts, and we have to go in, excavate all that now mushy, retained particles, and start all over again. So I would say lesson learned in the sense that we either build real bone with biomaterials placed in a way that we know that they will be readily regenerated, or always kind of use a membrane to separate the type of tissues that we want to regenerate. And the point I try to make with our residents is, if you want to build soft tissue, you build soft tissue. If you want to build hard tissue, you build hard tissue. So if you try to, do a horizontal regeneration of 15 millimeters, I mean, eventually, that you're substituting hard tissue with soft tissue, soft tissue with hard tissue, and down the road, that might cause problems, and vice versa.
Okay. All right. The audience, I see that we've got a question or two. As you guys have more questions, please send them in. You can send into the question bubble or put a comment. I think we can find them either route. We'd love to have your questions. So my next question for you is, we want to talk about your treatment protocol, but because I think you have a lot of research into that, both, how to clean the implant and, what to do, what not to do, how to regenerate the bone around it. And I'm interested in hearing more about that. But maybe I just want to start with, when do you, this is a question I've asked maybe every speaker we've had, because, since you spoke at our symposium, along with Tom Wilson and Amle Wong and several others on periimplantitis, and this was that was in 2022, and I think I sort of became a little more infatuated with this subject at that meeting. And so since then, this is a question that I ask everyone: is when does George Kotsakis remove an implant and just go ahead and place a new one, versus when do you treat? And I also find that sometimes it's like the answer is not like when could you regenerate, but also maybe just when is it more practical to regenerate versus, so maybe how do you differentiate those two thought processes, like can versus actually should?
Yeah, that's a very important question, to patients and clinicians alike. I think the first stratification has to happen at the level of, do I have a horizontal defect or do I have a vertical defect, an intrabony defect? We know that if I have a horizontal defect, there's very little that can be done. So at that point, we're not talking about regeneration. We're talking about kind of a resective approach with implantoplasty and whatnot. That is just something that I don't do. I extremely rarely do, because the aesthetics are always compromised, and as a result, the function is going to be compromised. If you had a number 8 or number 9 implant, you would never want to be apically positioned and flap and have that implant show through. So in my book, if we have severe horizontal defect, that's a good indication for explantation. Now, when we're talking about intrabony defects, vertical defects that we can regenerate, there's no real formal classification of their severity. But there's one by Rosen and Fromm that calls defects that are past 50% bone loss with, I think, over 7 millimeters of probing depth or something like that as advanced.
Yeah.
And I will tell you, we've tried to regenerate these cases. Sometimes it works, sometimes it doesn't, but I would call them unpredictable. So if we want to look at predictability and consistency, I would say if it's over 50% bone loss radiographically, which means that we're nearing, we got to keep in mind that if we get to more than 70% bone loss, that's usually where implants might start having a little bit of mobility.
Yeah.
So if we see 50% radiographically, probably it's more progressed clinically. So I'd say that might be an indication for explantation.
Yeah.
Anything less than that, I kind of give it a shot. And I think I brought that up for the first time, kind of my interaction with patients at the Osteogenic Symposium when we were in Phoenix. And I told people that what I tell my patients is, based on statistics, if I decide to regenerate that implant, if it's within 50% bone loss, there's a 50-50 chance I can fix it for you. And if that fails, we move on to explantation, which is the radical approach, or we can just jump to explantation right away. And really, honestly, never have I ever had a patient tell me, I don't want to do it. Let's go for the safe solution of explantation, because they're so invested and there's so much morbidity associated with that. Yeah. But as clinicians, sometimes we lose track of that, and we care more about, what's my reputation looking like if I start treating the tough cases and then they don't work out all the time.
Because if it's not your implant that you're fixing,
right?
You're saying that the success rate in fixing periimplantitis or generating those tissues for long-term health might be less than the success rate if you just started over.
I think absolutely that's a given. Yeah. That's a given. But when you weigh, I think we got to weigh pros and cons, right? Benefit to the patient versus harm and finances. And when you put that all in the mix, I'm a huge advocate of regenerative periimplantitis treatment.
Yep. Yeah. Perfect. And that 50% thing, that's kind of what I consistently hear. So it sounds like at least people are maybe getting a lot of different doctors from different backgrounds to agree on something is not always so easy. But it seems like the 50% seems to be kind of the standard with most people I've talked to. So let's talk about, you've got 50% or less. You're now trying to save the implant. How are you going to clean it?
Yeah. Well, that's so important, because I think that's the game changer, right? If we think about a peri-implant defect, a vertical peri-implant defect, that's no different in what you would do in an extraction circuit defect, where we know that GBR works perfectly. You guys have published so many protocols with, the cytoplasty immediate extraction circuits, even type 2 defects and whatnot, works every time. The fundamental difference in peri-implantitis, the reason why these predictable GBR techniques don't work, is that you got the implant surface that was super biocompatible. New surfaces, sandblasted, acid etched. I mean, they're perfect. The body loves them. Yeah. But when you place them in for the first time, but when they're contaminated, when we're talking about biocorrosion, when we're talking about mechanical damage, they're just not biocompatible anymore. So you not only need to fix the defect, but you got to fix that thing in the center of the defect that will actually now, get bone to build away from it. And we've seen a lot of histology in animal studies where if you don't treat the surface the right way, the bone grows near it but never touches it again, which means that we're going to have a failure very, very short term down the road. So what we found in our basic science studies, and finally we're able to translate to the human in the clinical trial that you guys helped us fund, and we're finally completing and publishing, is that there are two ways how we can treat the surface, and that's either chemical decontamination or mechanical decontamination. And we find that for different reasons, they can both lead to severe damage of the implant surface, that no matter what you put around it, I mean, you can put 100% autogenous bone, you can put BMP2, you can put anything you want, it's not going to work. And the reason why chemical treatments fail is because titanium absorbs them. Titanium is a metal and has a metal oxide on the outside, so it has great affinity for a lot of, long molecules like chlorhexidine, for instance. Okay. They get absorbed on the surface, and you not only have that bad surface, but now it's holding on to this chemical that is intended to kill things around it. That's what chlorhexidine was made for. It's kind of a killer for bacteria and host cells. In this case, it kills the bone cells that you want to grow on the implant surface. So that's one way how chemical treatments fail. And the second route, mechanical treatments, the problem is that the majority of mechanical treatments were made, and that's part of a really nice review that Alberto Monge and Homley Wang led, and I was part of. We just published it this year. at the IGOI, that's Craig Misser's journal. Really informative for the audience. They can definitely find a link in my website and download it if they want
Okay.
to. And what we're discussing there is that there are certain types of mechanical treatments, and we can break them down in abrasive and non-abrasive. And further down, we can break them down into contact and non-contact methods. So the majority of treatment approaches were contact abrasive approaches. One example is a titanium brush. Another example is titanium curette, ultrasonic tips, all those kind of things that work around teeth.
Mm-hmm.
But what they do is they abrade the implant. And under these inflammatory conditions, that abrasion we have shown in a couple of papers now that it leads to corrosion of the implant. So the implant kind of changes color, different oxides form on the surface, trioxides, tetroxides, monoxides. And that implant is just simply not biocompatible anymore. So what we're finding, and it's so interesting because what I just told you is all we knew by 2020. I remember right before the Osteogenic Symposium, there was the 2020 PICA Symposium where I was up there and I said, I have no answers, but I really know what you shouldn't do. So I just told people what not to do, and I couldn't tell them what to do at the time. But it was so interesting because all the stuff that we know now is finally pointing us to what to do. And what to do is use chemical methods that are, water soluble, readily removable, and just have kind of a washing effect for this bacteria. Because the bacteria form a biofilm on the implant surface, which is kind of like a slime. Mm-hmm. So we found that even if you throw, with a water jet, saline on it, that's going to do the job. It's going to cover the surface, it's going to pressure wash it away. So that way we can combine, sterile saline with a mechanical, non-abrasive, non-contact method of cleaning it, which is a water jet, for instance. Another way we can do it is mechanical contact, non-abrasive, like using a brush, like using a nylon brush, though, which is non-abrasive on the implant surface and kind of burnish that surface, get rid of the biofilm, but not irreparably damage it. This is where kind of the field is heading. And when it comes to using chemicals, I think we have a couple of options we're exploring now, like really dilute sodium hypochlorite and possibly very dilute hydrogen peroxide in concentrations where they can selectively kill some of the bacteria, but not kill the bone cells.
Okay.
Yeah.
Awesome. A lot of great information there. Definitely some stuff I had not heard before. Now let's talk about regenerating. We've cleaned the surface. We're using a mechanical, non-abrasive cleaning method. And then what does the literature say, or what does your research say we should do in terms of we should do, and maybe what we shouldn't do in terms of regeneration, and what's the capacity for regeneration?
I will say that there are very limited studies. I think I can only think of a handful of studies that have kind of started to approach that question. And the problem that we've had in the peri-implant literature is that the question you asked before, like how should we clean the implant surface, that hadn't been asked before. So people were thinking really, okay, let's say we clean it with whatever, which most commonly was titanium curettes, and then move on to try two different things to regenerate it. Let's see what happens. But the problem is that if you damage the implant surface with these titanium curettes, which for the first time we showed in our clinical trial that's getting published right now, that actually will lead to inability of the site to regenerate, then it's hard to compare the grafts. So I would say out of the very few studies that are available answering that question, where the implant surface still hasn't been destroyed by decontamination methods, we know for one that we cannot use a fastly resorbable biomaterial by itself. So there is a great study by the Stavropoulos team in Sweden where they compared autogenous bone with I think a xenograft, mm-hmm. and they found that there was kind of a paradox that autogenous bone alone doesn't perform that well in the context of periimplantitis. Okay. Likely doesn't perform, in terms of that long-term stability. At the same time, our experience has been, and a lot of studies show that you cannot have a simply osteoconductive graft. Okay. Because if you think about these defects, they're crater-like defects, right? We have kind of a circumference around the implant surface, and the bony walls where the blood supply comes from, they're so far away from the implant that the regenerative potential is really, really compromised. So we have shown, at least on the translational level, that we got to have something better than osteoconduction. So the couple of avenues that we can go at here would be either an osteoinductive graft, so a great quality DFTBA would be one option. Another option would be an osteostimulative graft, so a calcium phosphosilicate graft like the NovaBone morsels we're using in our study would be a combination. And what we're exploring now is the possibility of using either one of those types of grafts or even an osteoconductive graft, but improve its bone building potential by the addition of either growth factors or inductive factors. And examples are the combination of a graft with MD-gain. There's a study from Bern that has tried that with great results in ligature-induced perimplantitis. Combination of, let's say, FTBA, a graft that's osteoconductive but robust with PRF, for instance. Or like we do in our study, we're using a combination of the morsels at 70%, and then we're doing 30% autogenous bone, locally scraped it with a microscraper, just to get that osteogenic, osteoinductive potential of the autogenous bone to hype up our osteostimulative graft. But really, the reason why we're doing that is that we've published studies showing that because the surface is not as biocompatible anymore, we need that inductive capacity or that osteostimulating capacity, which means we got to bring more cells early on towards the surface. Because it's a competition, right, between bacteria, soft tissue, and bone cells onto the implant, onto populating the implant surface. And we really want to up the potential of the bone cells to do that first. And if we do that early on, then we're going to have successful and long-term stable regeneration.
Okay, so in your study, which I know from our discussions and following your research that you've completed it, it's not yet published, right? So I assume you're preparing manuscripts and preparing for submission and those sort of things. You're using 70% of the NovaBone morsels, combined with 30% autogenous that you're using with bone scrapers, I believe.
We're using the microscraper,
scraper, okay. And then you're covering it with a, I believe, is it our cross-linked collagen membrane, the Cytoplast RTM collagen, is that right?
We're using the Cytoplast RTM collagen, and I will say that we use the Cytoplast RTM collagen in the study with great results, but just because of handling in these tight defects, I really much prefer the porcine, the newer porcine
the Z-matrix
membrane that you guys have.
The peritoneum matrix. Because there's a little memory with that Cytoplast RTM collagen. But so it's a little more maybe space making. But the peritoneum is a little more just completely drapable. So maybe that I got you.
Because I just think that peri-implant defects usually we have robust bone walls around them, but it's kind of hollow in the middle. So the Z matrix does a great job adapting and conforming really nicely to that. And at least in my hands, it's an issue of just handling.
Awesome. And then I don't know what the rules are around sharing preliminary data or whatever, but can you talk a little bit about what did you learn? What can be achieved in terms of regeneration?
We can get, it's very impressive. We can get 1 to 2 millimeters of bone gain in these defects that were pretty challenging to treat. I mean, I told you before, we are now advising don't get implants that have over 50% bone loss, but we did get them. And we were able to treat some of them. So what was really interesting about our study is that we used the same protocol of biomaterials that we felt was optimal. So we used, as you said, 70% combination of the osteostimulated morsels, 30% autogenous to further enhance that. And we use the RTM collagen membrane for optimal wound stability in a way. Sorry, I said microscraper, but I meant the micros for locally.
The micros,
Which I think I also showed my technique at the conference. So we got that biomaterial combination that we felt was optimal based on all the preclinical studies and turned out to be. And we said, we're going to try 2 different ways of cleaning the implant surface, getting back to your original question. We're either going to abrade that with titanium curettes, or we're going to just clean it with a nylon brush. So we're doing mechanical abrasive versus mechanical non-abrasive. And we looked at 2 different things. First of all, we looked at, do we damage the implant surface? And that was striking. That was the most impressive result. We saw that long-term, 2 months out after you do the treatment, you have the surface abraded, continuously leaking titanium particles to the tissue. and, potentiating inflammation. And you have the other surface just not doing that, not changing the amount of background titanium levels. And what was even more striking was that we were able to bring the probing depth, I think, approximately 2 millimeters down in the group treated with the brush, which is massive compared to previous studies. And we were able to regenerate 1 to 2 millimeters within these defects, which kind of corresponds, depending on the type of the defect, to approximately 40 to 60% bone gain within an intra-bony defect. And that's very close to what we achieve our own teeth, right? When you do guided tissue regeneration, when you look at the classic Italian studies, you're able to regenerate 50 to 60% of that defect, and teeth do great long term. Mm-hmm. Now here in implants, we do a little bit less, 40 to 60% regeneration, but we accomplish that with reduction in inflammation. What's even more impressive is that if you don't use that non-abrasive method and you use a titanium curette, not only we were not able to get that bone growth, but actually implants started rapidly losing bone, further deteriorating to the point that we got implants with 50% bone loss, that 5 months later when we re-entered, they were just popping up.
Oh, wow.
So it's so mind-blowing that a little detail that, we all, as a clinician, I strive to do the best for my patients, right? So if I feel like I can just remove more biofilm, more bacteria with the titanium curette, I'm going to do it, mm-hmm. because that's the only instrument I have available. But like in that kind of, in our obsession to clean them, we end up doing such irreparable damage that at the end of the day, not even the best biomaterial in the world, not even the best surgeon in the world can fix. Yeah. Versus just using an implant-specific approach, as we've now published in our protocol, and achieving consistent results. And when I say consistent, I would say that more than 50% of the implants, even advanced periimplantitis, were able to get adequate regeneration and reach stability.
Okay, awesome. You mentioned this. You mentioned this protocol. I know that you have a protocol. It's like one sheet that kind of, shows what you're currently doing and what you did in your research. Where can we find that?
Yeah, absolutely. I think you guys were instrumental, because I forget if we had the idea or you had the idea to just get the protocol from our study that worked and really break it down.
We get a lot of questions about it, so it's a nice thing to make available to people who have questions about this.
Yeah, absolutely. And the thing is that we have a lot of this type of protocols for GBR, for teeth, but there was none for periimplantitis. So we're just very happy to put it out there. So I think they can find it both on your Instagram page. I feel like you guys have posted that. Okay. And it's also available as a single page PDF on my website. And I'd be happy, if we can share the link, and it's free to download. Yeah,
I'll put it in when we post this video, I'll put the link in there. But it's drkotsakis.com. I believe that there's no period between the DR and the K. So it's just no period, just drkotsakis.com. And you also have a newsletter there, so that people can sign up for it there. And so go there. And then also, a question that we get is, how do you diagnose periimplantitis? Like, how do you know that you reach the definition of periimplantitis or not?
Yeah. Totally. I get that question a lot, and I even get a modification of this question, that is, can we probe dental implants? So I'll tell you, consensus 2017, it's now on paper, World Workshop. Not only we can, but we have to, and it's a liability if we don't. Okay, so annually at the every periodic exam, I think it's our responsibility to probe implants gently, but still probe them. And it's kind of hard to diagnose periimplantitis because it has to do with the baseline of its implant that's different. An implant that is platform switched, an implant that's placed subcrestal, an implant that's immediate versus tissue level. All those things lead to different baseline probing depths and bone levels. So it's a little bit of a more complicated definition to be able to tell if an implant is healthy, has mucositis or periimplantitis. I'm very happy to share for the first time here that we've come up with a periimplantitis and periodontitis classification calculator app that's going to be available on the Apple Store. I'm hoping early next month. So we'll definitely keep everybody posted. We'll post the link, and you'll be able to just download it on your phone, plug in the BOP, probing depth and bone level of your implant, and get a suggestion for classification.
So if I go to
So
the
hopefully
App
that's going to
Store,
work.
I'll be able to find this in what, a couple of months?
Listen to that. I think that within 3-4 weeks, you should be able to do it. And there's going to be a link to download that for free on my website.
Okay.
Just
So we
to
can go
give
to your
everybody in the
website to
community.
find the name. Do you already
Yeah.
know what the name will be, or we'll need to go to your website here in a couple of weeks to find it?
Yeah, it's going to be PerioCalc app.
PerioCalc.
Yeah.
Awesome. So this kind of like, so you just enter in the different different parameters, like, what the bone loss is, how long the implant is. You enter in these different things, and it'll basically say, is it a yes or no? Is it binary, yes or no, that it's periimplantitis, or is there like a sliding scale?
It's yeah, we took the exact classification for periimplantitis right now. So the answer would be either periimplant health, periimplant mucositis, periimplantitis, periimplant soft tissue defect, or periimplant hard tissue defect, which is kind of the textbook definition. And based on the input, you're going to be able to get an answer, within a matter of a minute. Yeah,
That's really cool.
it's pretty neat. Very exciting stuff.
You developed this yourself?
Oh yeah, it's been a multi-year process, I'll tell you, but we were finally able to put it on the Apple Store, and I'm really proud of that. It's my little baby.
I don't know where you find the time, my friend.
I don't.
Hey, well, honestly, this conversation could go on another hour. We're already 9 minutes over. I appreciate your time. Maybe we could do a follow-up at some point in the future, because I know I got a lot more questions just related to titanium particles. I know we've got questions from the audience about zirconia implants. So I feel like this topic is sort of just like there's a jumping off point for so many different routes that we can go with it. Apologize to a few questions that we didn't get to, but I appreciate your time this evening, and really look forward to your publication coming out, and just appreciate your friendship and working with you to help solve these clinical problems that we get a ton of questions on.
Thank you so much, Shane. And before we go, just a little shout out. I want to tell you that I still remember when we talked, like 7 years ago, when we were designing our clinical trial. I kind of told you that I want to find a scientific answer to the problem, and there was no comparison of biomaterials. There was no like direct benefit to osteogenics in any way. But you guys came through, and you just supported our research, and now we're just able to have fascinating data that I think will be able to move the field. So really, really want to thank you for supporting this, and really thank you for supporting clinical science. Yeah, appreciate it.
Awesome. Well, thanks everyone for joining us this evening. This was fun. Hope everyone has a great evening, and we'll have a good night. We'll talk to you later.
All right.
Okay.
Thanks for having me,
George.
Good night.
Bye. Good night.